Hi, my name is Sally Mahood. Just in the interests of the time that was given to me, I did draw up a fact sheet that I thought might be useful to people, and I think it's going to get circulated. That way I'm not trying to quote you facts all over the place while I'm speaking. So, comparatively, Canada spends more on health and actually has less healthy citizens. We're in the top 4 per capita spenders on health, but we're in the bottom 4 of OECD countries for health status. And we're all aware, I think, that there's a growing gap between the least and the most healthy that's fueled by a skyrocketing income-wealth gap. But I'm not sure we all realize how that actually impacts on increased mortality, morbidity, and healthcare costs. In 2014, Canada spent 11% of her GDP on healthcare, and that's up from about 7% in the 1970s. Health budgets, provincially and federally, average about 40% of government expenditures, and they're rising. That's partly increased spending, but as Simon pointed out, it's also partly decreased revenue from tax cuts. It's not an apocalyptic situation, but it is worrisome and needs addressing. And mostly our dollars are heavily skewed towards acute or illness care. 1/3 of our money goes to hospitals, about 15.7% of it goes to drugs, 15.5% of it to physician services. And this reflects, I think, the ascendancy of a high-tech biomedical health model, particularly in end-of-life care. This drives up acute care costs, and it's added to by an aging population. Most of us will spend about 1/3 or 1/2 of all of our healthcare dollars in our last year of life. But 50% of our health outcomes are actually attributable to the social determinants of health, and the root causes of high-cost, frequent healthcare use are really entrenched in social economic status. And I'm not sure that we all actually appreciate this, that only 15% of illness is thought to be due to your biology. 25% of it might be related to your access to health care, but 50% of it is due to your socioeconomic status. So for virtually every illness category that you want to name, diabetes, heart disease, mental illness, suicide, chronic disease, infant mortality, there's a social gradient whereby the incidence is much higher the poorer you are. 50% of the $200 billion that we spend on healthcare annually in Canada is associated with the bottom 20% of income earners. So we can't really address healthcare reform without addressing these social determinants of health, many of which actually lie outside our traditional, narrow medical approach to illness. And the top social determinant of health is income. Food insecurity is also tightly linked to poor health status and a very robust indicator of how much health care you will use and how much it will cost. I think Peter's made the point here that housing is similar. Current estimates are that if we spend $1 in housing, we avoid $11 in healthcare expenses. And I can give lots of practical examples of that. Early childhood intervention addresses the cumulative impact that poverty has on children, and there's a net return of $6 for every dollar we spend on that. The impact of poverty on health is pervasive, and if we continue to see disease as a biological imbalance that results from faulty lifestyle choices, we really won't get anywhere. Health behaviors are linked to income and to control over your life. And if you don't know where your next meal is coming from, you are not thinking about quitting smoking for fear of that lung cancer 20 years down the road. And you simply cannot jog your way out of poverty from the point of view of health. Yet only a small proportion of our public health funds go to improving the social and economic conditions that make most people sick. And that needs to change. We also live, I think, in an era of what I would call maximally invasive medicine, what I would sort of call too much medicine and not enough care. A medicalization of life, with health increasingly treated as a commodity and sickness being sold really for financial gain. It probably always has been, but it's reached a high point in our society. So preventive rhetoric has us all afraid of what we eat, what we drink, what we breathe, worrying about what diseases we might harbor, and consuming medical technologies and treatments to find out what they are and try to prevent them. And this leads to overdiagnosis, overtreatment, overdosing. We have a deep belief that somehow early diagnosis will make a great difference, but in fact, most of the time it doesn't make a great difference. We have widened our definitions of disease, and there's always a new drug to treat these new pseudo-diseases. We have increasingly sensitive tests that find things that will never matter. And we have a general more is better, better safe than sorry approach rather than watch and wait, which is a much more sensible approach. I say that after 35 years in family medicine. Patients look for more tests and more treatments, and doctors fear missing things, and they do the same, and industries and professions benefit from these expanded tests and treatments. The result is really false reassurance to many people, a lot of anxiety for a lot of other people, increased interventions of questionable value that often actual harm to healthy people. So I'm going to just give you some examples. In Canada, for example, we have 3,600 therapeutic knee arthroscopies in the country every year. And we now know that if we do a sham procedure, meaning we put people to sleep and leave a little incision on their knee so they think they've had a procedure, both groups do equally well. But we're spending money on that. A healthy person who's subjected to 10 unnecessary tests has a 40% chance of a false positive result, meaning we tell them there's something wrong when in fact there isn't. Even the Canadian Association of Radiologists admits that 30% of CT scans are inappropriate and give us absolutely no useful information for patient care. And this all diverts very precious resources away from genuine illness and away from genuine prevention. And it results in a sort of market-driven generation of increased demand that's unrelated to actual need. What else is wrong? Well, we have federal lack of leadership in setting national standards for healthcare, in enforcing the Canada Health Act, and in addressing the big cost drivers in the system, such as drugs. We have a fragmentation of medical care. Many Canadians, 7.2 million, have no family doctor or primary care provider. They access their care in very irrational ways, in part because of this. They use emergency rooms for non-emergent matters. They enter the healthcare system not through a single door, but sometimes through several, and sometimes at the same time through several. And they have no continuity of care with any provider or team of providers, and therefore no trust in the care they're getting or the advice they're given. We have a publicly funded healthcare system that's essentially privately run, with an ongoing tolerance, I would even say encouragement in some sectors, of the fee-for-service model for paying doctors. This is perhaps the biggest irrationality in an irrational system, and we've been saying it for decades. It's a pervasive incentive system that allows entrepreneurs basically access to the Medicare trough. It rewards volume, not quality, procedures, not prevention. It encourages wasteful interventions, and it discourages a rational distribution of healthcare professionals' labor. A lot of money is spent without any accountability really for what it achieves. I think privatization is a major issue. We already have very significant privatization or for-profit healthcare in Canada. 30% of the money that's spent is in a private sphere. And contrary to what you are told, increasing private healthcare is a big factor in escalating our costs. The aging population, the gray tsunami, has been blamed, but it's actually a relatively small driver of increased costs compared to salary inflation, expansion of new and often privatized technologies, diagnostics, drugs. Rising healthcares are attributed about 7% to population growth, 14% to the aging population, 19% to inflation, but a full 60% to increased utilization. There are fake solutions and there are real solutions. More privatized healthcare is definitely a fake solution. We constantly hear that Medicare is unsustainable, and I think this is aimed at softening us all up for more privatization, for two-tiered care and benefits, nibbling away and dismantling Medicare by stealth, proposing parallel private options as some kind of escape valve for an overloaded public system. This is the number one fake solution, whether it's privatized MRIs, privatized health clinics, health insurance, for-profit clinics, you name it. It caters to everyone's public fears about long wait lists, which I think are exaggerated in that most people who have urgent healthcare needs actually get attended to fairly urgently in our system. And it basically offers preferential access to investigations and treatments for the few at the expense of the many. There's extensive evidence for this. For-profit options have poorer outcomes, whether we're talking about clinics, nursing homes, hospitals. They cost considerably more. They're profit maximizers, not cost minimizers. They skim off the easiest, cheapest patients and procedures, cherry picking. They avoid the aged, the chronically ill, the poor, who are the big drivers of increased expense. And they do not relieve pressures in the public system, and instead evidence tells us consistently that they lead to more inequities, poach or siphon resources, whether those be human or otherwise, from the public sector, and they actually increase public wait times. Throwing the door open to any investigation or treatment based on ability to pay, not medical need, is stupid and wasteful. And further shifts resources, again, away from the sick to the worried well, the impatient, and the wealthy. Medical interventions should be based on medical need, not ability to pay, and they should be ordered and provided in accordance with evidence-based guidelines about their usefulness, their indications, and then prioritized based on medical urgency. And this is a very important, genuine solution, but we do need evidence. We need independent assessments of new technologies, interventions, and drugs that looks at their actual value to patients and sets criteria then for access to them. What other genuine solutions? First and foremost, as I've tried to point out, we need to shift health dollars upstream. We need to spend more on the right kind of health. We need to address the causes of illness, and we need to rethink how money is distributed between treatment and prevention. And I'm not talking here about what I consider to be phony concepts of prevention, such as wellness, but genuinely addressing poverty, food insecurity, substandard housing, educational and other types of inequity, racism. Income determines health, so ensuring adequate basic income is our number one priority. There are various options for doing this. I'm not an expert on them, but some combination of beefing up our current income supports, providing a guaranteed annual income, increasing minimum wage for those many of us of people in the province who actually work full-time but don't make enough to live a healthy life. So a living wage applied with minimal bureaucratic burden. I listened to Peter and thought of all the hours that an MD, me, spends helping people fill in the endless bureaucratic forms they need to fill in to access any of these income supports. It's ridiculous. And we need this that allows people to work to the extent that they can, and a program that isn't an excuse for withdrawing other universal social supports. There's ample empiric evidence that this would have a very significant impact on healthcare and on healthcare costs. And that's not the only reason to do it, but it's one. The next priority is primary care reform, and to do this, we need to end fee-for-service remuneration of doctors. The model I think we should adopt is a system of multidisciplinary health clinics in every community, staffed by teams of providers, doctors, nurses, nurse practitioners, social workers, pharmacists, counselors, whatever is appropriate to that particular community's needs. And these teams they would optimize health human resources based on who can do the job best, not who can bill for it. Every single citizen should be connected to such a facility. It would be their entry into the healthcare system. It's what the Canadian College of Family Practitioners calls the patient's medical home. These clinics could be located in community hubs, in schools, wherever, but they're the front door to all health services and to the other integrated social services that we know are integral and important to health. They could develop continuity relationships with individuals and with the communities they serve. They could deliver a whole range of health services that are needed, but also be the route to acute care if acute care is needed. They could also be the focus for shifting care out of expensive and often inappropriate hospital care to a more appropriate community setting. For example, they could be the hub for improved home care and for mental health services. The closest equivalent that I could think of was the public school system, getting rid of private fee-for-service model and instituting basically a salaried public service model of primary care like our schools. Okay. Pharmacare, I couldn't leave without saying something about that. It's an essential needed transformation. Canada's drug prices are about 30% more higher than equivalent countries. And many Canadians cannot afford needed medications. 1 in 5 of us has no supplemental drug coverage, and that's going to get worse with precarity of employment, I think. We need a strong, independent drug review process that decides which drugs we really need, not the thousands that are available, many of which are Me Too drugs. We need to know what we really need, a national essential drug formulary, and then we can competitively bulk purchase those drugs that we really need. Providing medically necessary drugs does improve health outcomes, and there are excellent models of the cost savings that we could have through a pharmacare program if we choose drugs based on evidence, not based on marketing. Final word about mental health care, a long, I think, neglected area of funding and care. The acutely mentally ill definitely do not belong in a busy emergency department, which is where many of them are currently sitting. We need an alternative location for these patients. We need resources put into psychiatric day programs, providing intensive psychosocial interventions. We have long wait lists for psychiatrists and poor access to counselors unless you have private insurance. The primary healthcare centers I'm suggesting would be ideal locations for counselors, for addiction services, for community psychiatric nurses doing outreach, for life skills coaching, for supportive community counseling for the mentally ill. These programs could triage what I think we know is a very high incidence of mental illness in our communities, but I would also point out that many of those mental health problems are amenable to an upstream approach to the social determinants of health. So these aren't all the answers we need, but I'm hoping to start the conversations we need to have to engage in true transformational change. Thank you.